Good afternoon, everybody. How are you going? I hope you're well. Dr. David Johnson here from the Back Pain and Functional Movement Training Centre. Today I'd like to create a little video for our patients that just provides an overall framework of understanding of the Functional Movement Training Centre NeuroHAB movement therapy program. Okay, so a lot of patients that come through our doors will suffer from chronic low back pain. Okay, chronic low back pain, and importantly, symptoms. That's very important because we know that low back pain is not a diagnosis. Low back pain is a symptom, and diseases cause symptoms. All right. So in all of medicine, it is standard to try to control symptoms. Okay, so that's symptomatic interventions. But as a fundamental principle, if we only deliver interventions that control symptoms and we ignore the disease, then it's highly likely that you're going to fail in managing the problem. So this is where NeuroHAB comes in as a fairly unique intervention, because it is very much targeting the cause of the symptoms. And what we need to really conceptualize is that chronic low back pain symptoms are the consequence of a functional disease. Okay, back pain symptoms are a consequence of a functional disease. They're not a consequence of arthritis. Okay, they're not a consequence of bulging discs. They're not a consequence of getting older, age. They're not a consequence of being unfit. It's not a consequence of being overweight. It's not a consequence of having weak core. Okay, so this is what is not causing back pain. These are all secondary structural symptoms or secondary effects of this functional disease. Okay, and the functional disease that we're referring to is biomechanical. Okay, it's a biomechanical functional disease. Okay, and the easy, nice, neat way of saying that is movement dysfunction. Movement dysfunction. Okay, so if we reverse movement dysfunction, we have intervened by reversing the functional disease that causes all of these problems. And of course, people with low back pain, they may start to develop arthritis, and they may get bulging discs, and they may become unfit, and they may become put on weight, and they may develop a weak core. But remember, these things come secondary to this problem down here. And a lot of people don't even understand, and they have not been told in all of their years of suffering chronic low back pain, they've never even heard the term movement dysfunction. They've never even been told that they have a disease that causes their back pain symptoms, and that's quite alarming and concerning. That a patient can go to see many specialists, GPs, doctors, various therapists within the back pain therapeutic industry, and they are not informed or educated about their functional disease that is causing their chronic pain and disability and all of the other downstream consequences that results in. So what is NeuroHAB? Okay, NeuroHAB is a rehabilitation program that focuses on, it's a rehab program. Okay, it goes for 8 weeks, and it's generally 2 visits per week, each of which is about 1 hour long. that consists of skill acquisition. Okay, skill acquisition. It is not an exercise program. There's no point doing an exercise program. It is not a fitness program. It is not a core strengthening program. It is not Pilates, because in fact most of our patients have done that till the cows come home, and it has not fixed their back pain. So it's a skill acquisition program. It is not exercise. Okay, and skill acquisition is by definition a characteristic of a functional intervention. If you're doing a functional intervention for someone, you actually are upskilling them, okay, and that's very different to laying on a table and receiving some massage therapy or adjustments or an injection or surgery. They are structural interventions, they're not functional interventions, okay? So what is the goal of NeuroHAB? I just said it's to eliminate the disease of movement dysfunction, but if we break that down a little bit further, we are trying to obtain stability of the we're trying to obtain stability of the lumbopelvic spine. Okay, so that means all of our little vertebral bodies that form our lumbar spine and our sacrum. Okay, here's our disc, here's our facet joints. Okay, so these are what we refer to as spinal motion segments, and they're just spinal joints. And we want to obtain stability of these joints. We want to obtain stability because by definition, instability or an unstable spinal motion segment causes pain and disability. Okay. And often that instability that arises does end up requiring surgical intervention. Okay, that often does end up requiring surgical intervention. And what does the surgical intervention do? It's to assist with the reacquisition of stability. Okay, but if we can intervene in a timely manner, then we can restore stability without the need for any adjunctive surgical intervention. All right, so how do we put that into a framework of understanding? I'll just rub this out. So there's three primary factors that determine stability. Okay, three primary factors that determine stability. And I'll explain to you what the most important factor is when it comes to intervening as early as possible in your back pain journey. There's three primary factors that determine stability, and we're going to call them the active factors, and the passive factors, and the neural control factors. Okay, so that's what I want you guys to really remember. The most important one in the early phases of back pain is the neural control. The active factors are represented just by your muscles. Okay, so how active are your muscles? How responsive and how strong are they? And then the passive factors are all those other non-contractile elements that make up your lumbar spine and periarticular soft tissue. So we can refer to that as, you know, your bones, your ligaments, your tendons, your discs, your cartilage. Okay, cartilage. So they're all the passive factors that just live in your back. And the neural control is your central nervous system ability to coordinate these elements to move biomechanically proficiently. Okay, so that is the most important factor that determines stability for most people. Most people we see have the muscle contractility or the muscle strength that meets the demands of their lifestyle, meets lifestyle demands. Okay, so you might be an accountant, you might be a teacher, you might be a banker. You have muscle activity and contractility and strength and power and endurance that meets your lifestyle demands. Okay, if you're an athlete and you have back pain, you'll already have the muscular activity to meet your athletic standard as well. We don't really need to make people all that much stronger, and that's why core strengthening doesn't fix back pain, because it's trying to focus on an area of deficiency that isn't deficient. Okay, people are told all the time, strengthen your core, but they don't need to strengthen the core because they might just be sedentary. They might be an accountant, they might be a teacher. They don't need to have a very strong core to be an accountant or teacher. The passive structures, most people have relatively well preserved discs and ligaments and joints such that we don't need to modify those structures. So we don't need to do surgery on people straight away when they come and see us with back pain. There's no need to modify those passive structures because that's all that surgery is doing. It's cutting out a disc or cutting out a joint or freeing up a nerve, putting in nuts and bolts to stabilize the motion segment artificially. And most people who first present to me, probably 19 out of 20 patients, do not need any surgery when I see them, and they're coming to see me after having years of pain, right? So 1 out of 20 patients may come to see me and their passive structures are so far gone that yes, surgery is required up front. But most people do not need surgery for those passive elements of the spine right from the beginning. So if they don't need that from the beginning, these are all equally important, but we know that we don't need to do anything to those things. That leaves one thing that is most important that we can optimize to regain stability. Okay, because that's the ultimate goal when we're restoring a pain-free spine. These three things. So we don't need to do anything here. So that means that the most important thing we need to actually fix up is the central nervous system's coordination of movement. Okay, so we've got the muscle already, we've got the structural integrity preserved. All we need to do is fix up the neural control mechanisms that is controlling how skillful these structures are, and then Bob's your uncle, we are proficient in all three domains that determines stability. Okay, so I hope that makes sense because it's a very fundamentally important concept, and once you understand that neural control is the real bang for your buck intervention, and that's why we call it NeuroHAB, because it's rehabilitation. That's why we coined the term NeuroHAB in 2015. We've been doing this for over 7 years now. Rehabilitation of the nervous system control, okay? And it's the only program probably in the world, definitely in Australia, that has this as the primary focus of its rehabilitation. So NeuroHAB. Now, how do we do that? How do we get people more coordinated? Like I said before, 8 weeks, 2 times a week, it's repetition, 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 correction, correction, learning from the movement therapists who know that they have a genie in the bottle solution for one of the world's leading cause of disability, and just turning up and having your brain educated and becoming more skillful at your activities of daily living. Once you've got those skills, you then apply them into your everyday life, and then you're effectively rehabilitating every second of every waking moment, and you then have the power and autonomy to steadily and slowly get better over time. Okay, so we're instituting and promoting your own body's natural healing process without any dangerous interventions and things like that. Okay, so that's the concept that we're trying to promote. And how do we do it? How do we do it from a practical standpoint when it comes to the lumbo-pelvic spine back pain? We focus on these movement points of performance, and sadly, people don't really know what we mean. They don't know what it means to be moving biomechanically well. So there's only 5 things that we focus on, and we can triage them almost into this sort of order. So neutral spine awareness, neutral spine awareness and maintenance. Okay, when you're bending, during bending, tasks. Okay, and you will bend to pick things up in front of you, several thousand times a day. I have read some studies that say that we, on average, in modern society, bend about 5,000 times a day. So we have to bend well. Okay, the next thing is, when we bend with hip-centric rotation. Okay. That means we rotate our body as we bend through the hip joint, which of course is a lovely little ball and socket joint. Okay, it's a ball and socket joint. There's the femoral head, there's the femur shaft, and here's the socket, or the acetabulum of the pelvis. It's designed for rotation. Okay, remember, the spine is just a bunch of building blocks, Lego blocks stuck on top of each other. It's a support strap. It's not really designed to be rotating 5,000 times a day. This is the hip joint, hip-centric rotation. The muscles that we want to engage when we do these bending tasks is the posterior kinetic chain. Okay. Posterior kinetic chain powered movements. These are the most powerful muscles of your body, and they are positioned on the back half of our body, and by engaging in those muscles in a coordinated way to do our bending tasks, we actually develop a very stable environment for all of these joints. Okay, so we don't really want to bend with our knees and our spine deactivated to do things, because that effectively switches off the posterior kinetic chain, and therefore we lose stability of those spinal motion segments, and we then have a flow-on effect that loses our neutral position. So we're sort of immediately starting to break rule 1 and rule 2 if we don't engage the posterior kinetic chain musculature. Rule number 4 is unloaded knee positions. Unloaded knee positions. And by maintaining unloaded knee positions, it kind of forces us back to reinstate these movements, all right? So if I start to do things like this, okay, and I'm loading my knees, which means our knees are coming forward, then I'm going to, almost by default, start to break the earlier triage and prioritized rules. So if I make sure that my knees are not loaded, I then push myself back into this biomechanically more proficient position. I've engaged my posterior chain. I can feel the activation of the posterior kinetic chain. I've now hit a neutral spine position, nice and neutral. I'm now rotating and bending and doing my task with hip-centric rotation. So there's a flow-on effect that enhances rule 1, 2 and 3 by maintaining this unloaded knee position, okay? And then the last rule is proficiency limited range of motion. Proficiency limited range of motion. Okay, so if I'm very good at moving my body to pick up something that's on a coffee table and I feel fantastic, I'm moving well and I can do it, but if the object is on the very bottom shelf of a cupboard and I currently, that's the key word, I currently am finding it difficult to maintain all of the rules above, and I need to get down to that bottom shelf to get something, then I don't want to break all those rules simply to do that task, because if I do, I will have to break the rules to do the job, and that creates a insult to the spinal motion segments, which is exactly what we're trying to reverse. So proficiency limited range of motion is necessary as you're starting to heal and as you're starting to get a healthier spine. But as your spine gets healthier and healthier, that proficiency limited range of motion is improving. So over time, that range of motion gets greater. So now I can actually get lower and lower and lower and lower and lower, and I'm not breaking any of the rules of NeuroHAB or the movement proficiency points of performance. And that's why we triage in that way, and that's why that is listed as our fifth fundamental movement point of performance. If I do have to pick up something like that, there'll be other ways that we can achieve that goal, okay, such as that. And so I'm still not breaking the rules, and now I can get down much lower. I'm still not loading my knees, I'm maintaining hip-centric rotation, I'm maintaining a neutral spine, and now I can get down to that bottom shelf and do a movement. So that's what we can teach you in NeuroHAB, is to still allow you to engage in life activities, but we don't break the rules to do it. There are some circumstances in the early days where there may not be a very good solution, and in that case you just have to hold off some tasks, okay, for a little while, until the spine gets healthier and that proficiency range of motion increases, and then you can resume doing those tasks, okay? And that's how we can continuously, every day, drive health back into the spine by delivering constant movement proficiency. Okay, so the program, the NeuroHAB program, is very much a qualitative program. It's a qualitative program, and it has qualitative measurements. Okay, qualitative. Okay, so when we are measuring the progress of patients doing NeuroHAB, we're looking for quality. Okay, we're not so much focused on the quantitative metrics of movement, such as we're not so much focused on what your range of motion is, how fast you do it, how strong you are, how powerfully you are doing it. We are more focused on the quality in which it's delivered, and that's why the skill set is that of a movement therapist. Okay, there is no great value in measuring angles and measuring distances and measuring ranges of motion, angles, because they're not that important for us. We know that they will all slowly and steadily get better over time simply by adhering to these rules, because it's a qualitative program, making sure that we stick to good quality movement. Everything else will slowly start to head in the right direction. The trend line of improvement will be a physiological certainty. Okay, and with that, your chronic pain and disability it'll be a certainty that that will start to improve over time. If you don't leave it too late, if you leave it too late, then yes, we have to then start to focus on those other active and passive elements that determine stability. Okay, if you get in early enough, all we have to do is focus on the neural control, which is NeuroHAB, and you can make a very, very good recovery. And from a very early stage, you will perceive, you will know that you are on the right trend line. Finally. Okay, I think that's enough information for today. Thank you for listening. Please get in contact with us if you'd like more information. We have a wonderful team, and we're all very passionate about fixing people up from their chronic pain. So look forward to hearing from you soon. All the best. Bye-bye now.